Hey everyone, let's talk about cholelithiasis or gallstone disease. If we talk about epidemiology a little bit, so gallstones affect 10 to 20% of adults residing in United States, Canada and Europe, and 20 to 40% in Latin American countries, and only 3 to 4% in Asian countries. Okay, in the United States, about 1 million new cases of gallstones are diagnosed annually, and two-thirds of the affected individuals undergo surgery, resulting in removal of 25 to 50 tons of stones per year, which is insane. Okay, so there are two main types of gallstone. First one is the cholesterol stone. They contain crystalline cholesterol monohydrate. 80% of the stones in United States, Canada and Europe are of cholesterol type. And second type is the pigment stones, which are made up of bilirubin calcium salts. So cholesterol gallstones are more prevalent in United States and Western Europe, and uncommon in low income countries where pigment stones are more common. Okay, so if we talk about the prevalence and the risk factors of stone, the major risk factor for gallstones are, first one is age and sex. Okay, in 80% of the individuals with gallstone, the only identifiable risk factor are age and sex. So the prevalence of gallstone increase throughout the life. In United States, less than 5 to 60% of the population younger than 40 years of age have stones, in contrast with 25 to 30% of those older than 80 years of age. The prevalence in women is about twice as high as men. Okay, so first you have to remember 40, second you have to remember female. These two things you have to remember. In females also, there is pregnancy and oral contraceptive. These are again risk factors for gallstones. And other than that, we have obesity and insulin resistance, rapid weight reduction, gallbladder stasis, inborn disorders of bile acid metabolism, dyslipidemia syndromes. These all are the risk factors for cholesterol stone. If we talk about pigment stones, the most common risk factor is the chronic hemolysis, for example, sickle cell anemia, hereditary spherocytosis, which leads to formation of unconjugated bilirubin and thus forming pigment stones. Next up is the biliary infection and other GI disorders like ileal disease, Crohn's disease, ileal resection or bypass, cystic fibrosis with pancreatic insufficiency. So these are the risk factors for pigment stones. So this you have to remember. Other than this, there is heredity, as we have already seen, and environmental factors like estrogen, because they increase hepatic cholesterol uptake and synthesis, leading to excess biliary secretion of the cholesterol. This affects explain the increased risk of gallstone disease with oral contraceptive use and with pregnancy also, because in these conditions also there is estrogen excess. Other than this, obesity, metabolic syndrome and rapid weight loss are also strongly associated with increased biliary cholesterol secretion. Next up is the gallbladder hypomobility, which means any setting in which gallbladder mobility is reduced, such as pregnancy, rapid weight loss, and spinal cord injury. In most cases, however, gallbladder hypomobility is without any obvious cause. So, if we talk about pathogenesis, how are these stones being formed? First up is the cholesterol stone. So, cholesterol stone, if we talk about cholesterol stone, bile formation is the only significant pathway for elimination of excess cholesterol from the body, and either as free cholesterol or as bile salt. So, these cholesterols are eliminated from our body through bile formation. When there is excess of cholesterol, and but not if no, not enough bile to render it soluble and making it doing the elimination or excretion, these cholesterol they concentrate and they form the crystals. Okay, so cholesterol is rendered water soluble by aggregation with these bile salts and lecithin. When cholesterol concentrations exceed the solubilizing capacity of bile, means supersaturation is happening. So cholesterol can no longer remain dispersed and then it crystallizes out of solution. Again, cholesterol gallstone is enhanced by hypomotility of the gallbladder, which promotes crystal nucleation and mucus hypersecretion, which will trap these crystals, thereby enhancing their aggregation into the stones. If we talk about pigment stones, they are made up of insoluble calcium bilirubinate salts. This is asked, you should know this. And when they form when bile contains a high concentration of unconjugated bilirubin, which happens when there is either hemolysis or certain infections of the biliary tract, such as liver flukes. Cirrhosis and Crohn's disease are also associated with pigment gallstone. And in cirrhosis, reduced bile salt synthesis hinders solubilization of the bilirubin. And in Crohn's disease, what happens is there is increased concentration of bilirubin, likely due to altered enterohepatic cycling of bilirubin. If we talk about morphology and how these stones look, so cholesterol stone, they arise exclusively in the gallbladder and they consist of 50 to 100% cholesterol, which means if they are 100%, they are known as pure cholesterol stone, which will be pale yellow. Increasing proportions of calcium carbonate, phosphatase and bilirubin impart gray white to black discoloration, as we can see in this figure over here. These are all cholesterol stones, and so this wall of the gallbladder is thickened, and these are cholesterol but not 100% because they are not pale yellow in color. Okay, so the wall is thickened and we have multiple variable sized cholesterol stones with variable concentration of either calcium carbonate or phosphate. They are ovoid to form and they occur singly, but most often are several with faceted surface resulting from their apposition. Most cholesterol stones are radiolucent, although as many as 20 may contain sufficient calcium carbonate to be radio opaque. If we talk about pigment stone, they arise anywhere in the biliary tree. So this is the main difference. Cholesterol stones will be exclusively in the gallbladder, whereas pigment stones can arise anywhere in the biliary tree, and they are classified into black and brown, two types of pigment. In general, black pigment stones are found in sterile gallbladder bile, while brown stones are found in infected intrahepatic or extrahepatic ducts. The stones contain calcium salts of unconjugated bilirubin and lesser amounts of other calcium salts, mucin, glycoprotein, and cholesterol. So the black stones are usually small, numerous, and fragile to touch. The brown stones tend to be single or few in number and have a soft, greasy soap-like consistency due to presence of fatty acid salts released from biliary lecithin by bacterial phospholipase. Because of calcium carbonates and phosphatase, 50 to 75% of black stones are radio opaque, and brown stone which contain calcium soaps, they are radiolucent. Okay, so most of the black ones are radio opaque, whereas the brown stones are radiolucent because they contain calcium soaps. If we talk about clinical features, so gallstones can be asymptomatic for decades, and 70 to 80% of individuals with gallstones never develop symptoms. In a minority of individuals, however, the clinical manifestations are striking. They are usually right upper quadrant, or epigastric pain will be there. Often excruciating pain will be there, which may be constant or less commonly spasmodic. Such biliary colic is caused by gallbladder or biliary tree obstruction or by inflammation of the gallbladder itself. So pain often follows a fatty meal because the fatty meal will induce gallbladder contraction to release the bile, thus which presses a stone against a gallbladder outlet, leading to increased pressure and eventually pain. More severe complications include empyema, perforation, fistula, inflammation of the biliary tree, cholestasis, and pancreatitis. So, the larger the stone, the less likely it is to enter the cystic or common ducts to produce the obstruction. Thus, the very small stones or gravel, they are more dangerous because they will come out and they will obstruct. Occasionally a large stone may erode directly into the adjacent loop of small bowel, generating intestinal obstruction, and this is known as gallstone ileus. Gallstones are also an important risk factor for carcinoma of the bladder. Okay, so in this picture we can see pigment stones. These are the black stones. They are several multifaceted gallstones, and otherwise it is an unremarkable gallbladder. So this is a patient with mechanical mitral valve processes which led to the chronic hemolysis and formation of the pigment stones. So this was all about cholelithiasis or gallstone disease. In the next section we'll talk about cholecystitis. Thank you so much for